When you're designing the post-anesthesia care unit, it's very important to take into account some of the things like location and size. Um, the, the best location for a PACU is close to the operating room, which with easy access to the lab, the X-ray, the blood bank, and also in many cases it's an advantage to be close to the intensive care unit. The ideal size for a PACU is usually 1.5 square meters per bed. 1.5 bed per OR. In Aruba, we have 5 ORs, so it would be advantageous to have about between 1 and 8 PACU beds. We recommend it is recommended to have about 12 square meters per patient, and the distance between patients from bed to bed should be about 1.5 meters to 2. This is of course ideal. It doesn't always it's not always able we're not always able to apply these requirements, but in Aruba we're doing very close to the what is recommended here. Usually we work with faller cots with rails on both sides. We have piped oxygen, vacuum, and air in case we need to do suction and or apply ventilators. Um, Multiple electrical outlets, large doors, good lighting, and ideally it would be good to have isolation for immunocompromised patients. Here we can see a picture of the intensive care here, of the PACU here in Aruba. If we count, we see we have 1, 2, 3, 4, 5, 6, 7, and you cannot see it on the picture, but there's an 8th and a 9th here on the wall that's facing the back of this picture. So we have at least 9 stations where we can have our patients monitored post-operatively. This is an example of a Fowler's cut with rails on each side and wheels. This is ideal because if you need to, you can raise the head of the patient after surgery, which is often very advantageous. But also often these beds can go into Trendelenburg or anti-Trendelenburg, depending on what you need. And often the back part or the head part of the bed and the back part of the legs can be removed so that you can easily get to the patients when you're working with the patient. Here we can see an example of our PACU here in Aruba, and we can see there's air, there's suction, this is oxygen, this is air, and this is suction with extra lighting and also extra electrical outlets. This picture is showing large doors, which is very important because often you have special beds, and nowadays the hospital beds are very large, so you can always get through the door if you need, even if you have nurses and doctors on each side of the bed. Very important is to have good lighting. Here in our PACU we have natural light, but we also have electrical lighting. What kind of equipment we need at the PACU? Well, we need a tray with emergency drugs. We need, of course, to be able to have anything needed to do airway maintenance, like a laryngoscope, endotracheal tubes, all kinds of masks and airways, ambu, venturi mask, tracheostomy sets, intracardiac device sets, and transportation ventilators. So you can usually treat any emergency that comes up at any given moment. We have these cars that are sort of standard in every OR and in also on the PACU. And these drawers, we will see a picture inside the drawer, contain, among other things, the medicine that are mentioned here, like, for instance, adrenaline, atropine, rocuronium, which is a muscle relaxant, chlorpromazine, diclofenac, droperidol, ephedrine, etomidate, fentanyl for the pain management, furosemide, gentamicin, glycopyrrolate. Glycopyrrolate is like atropine but doesn't give as much tachycardia. Ketamine, metamizole, metoclopramide, metronidazole, midazolam, naloxone, oxytocin, eye drops, otrivine for the nose if you need to, paracetamol for pain management, phenylephrine for the blood pressure, Diprivan, salbutamol, and verapamil are some of the medications that are available, and also all types of needles and syringes and the labels that we use are always available. Here is an example of a standard tray with all the medication. Here we can see like the propofol, the etomidate, ketamine, different medication. Usually it's well labeled and easy to find, and it's more or less the same everywhere on the OR. Some of the medication, like the narcotics and medication that are not used too often, are put in locked closets and drawers, and everything is very well labeled, so we know where everything is. But also, if you need a mask, you need gloves, you need syringes, you need special equipment for transporting the patient, everything is available. The personnel, well, our PACU uses mostly intensive care nurses, so they're trained on the intensive care or emergency medicine. Usually, you would like to have at least 1-on-1 ratio for the patients, but in Aruba we have 1-in-3 ratio, which is good, not ideal, but good. Sometimes it gets a little bit too busy, but we can always control the flow of patients by announcing that the PACU is full. We use different type of monitors. Of course, every patient needs to be monitored for the electrocardiogram, pulse oximetry, non-invasive and sometimes invasive blood pressure, end-tidal CO2, temperature, and also available we have a bladder echo to see if the bladder is empty before sending the patient away, especially patients that get spinal anesthesia. You can sometimes have problems urinating, or even patients that get parenteral or regional narcotics. You can get sometimes that they have difficulty emptying their bladder. So we have to know that the bladder are empty before we can send them to the wards or home. As I mentioned before, here we can see one of the monitors. This is a very complete monitor which can do, among other things, the EKG. It can monitor non-invasive and invasive blood pressure. It can monitor the plethysmogram. It can monitor saturation. It can monitor CO2, temperature. And here we can see, it's not too clear, but here is the defibrillator, which we need in case we need to defibrillate. Of course, we have an EKG machine to, if we want to do some diagnosing, we can use that. We also use infusion pumps, which you might see here. It's not too clear, but we have infusion pumps. Oxygen and vacuum is available everywhere the patients have a station. We also have a special refrigerator for blood and plasma. We have universal blood. Usually it's O negative, in case we need that in a rapid fashion. But also if we collect blood and we need to keep it, we can use the special refrigerator to keep the blood. So that's also very handy to have. It's close to the OR and it's inside the PACU. Here we can see the nursing station. The nurses don't get to sit too much, but they always need a place to be able to write down and to maintain the records. So you can also see the computers here. And at the same time, they are very central, so they can watch the patients and see who's coming in and who's leaving. And from here, they can do almost everything. Besides that, in the back, you can see there's a wet area where if you need to, um, you know, clean a patient or have a urinal, you can have that there. We have special machines to clean the urinal and or to dispose of the urine or the feces. The criteria from shifting from OR to the post-anesthesia care unit. Well, we always try to have the patient as much as possible conscious, awake, and responds to simple commands like stick out your tongue, open your eyes, answering questions like do you have any pain, can you breathe deeply, things like that. Also, we like to have the patient hemodynamically stable. So once we leave the OR, we know that in the transportation and once they get on the PACU, we're not finding ourselves in a hurry to help the patient with whatever is going on. We always evaluate clinically how the neuromuscular blockade recovery is. Can the patient lift his head? Can the patient stick out their tongue? Can they do breathing? Often, if they're intubated, we can tell how much the tidal volume is and the minute volume. So we can tell how well the neuromuscular blockade is recovered. Oxygen is our main friend, so we always have oxygen at hand, and we also for us it's very important, especially in lengthy operations, to have the patient be at a good temperature. So as much as possible, we try to maintain the patient at normal thermia. We usually, from the OR, we translate the patient to a Fowler cut, and we raise the side rail, so the chance of the patient rolling over and falling from the bed is minimal. Once we handed the patient the PACU, usually the anesthesiologist or the anesthesia nurse and or the PACU nurse decides whether the patient is good enough to go back to daycare or the wards. Sometimes, if the patient went to the daycare or to the wards, mostly the daycare, because after daycare they usually go, of course, to their home. We find that the patient has to come back either because the wound is bleeding. That's one cause. A very common cause is that the patient is vomiting still too much, and not often, but it can happen also that the patient is not recovering from fast enough from the regional anesthesia, so they cannot empty their bladder or move their legs and or stand and walk on their legs. So then we have to evaluate if the patient has to come back for recovery or the patient has to be admitted before deciding that they're safe enough to go home. At the PACU, again, the patient is connected to the EKG. We're checking their oxygen pulse saturation, their blood pressure, usually non-invasive. If needed, they get oxygen therapy. This is when the patient starts to be more aware. So often pain therapy is important and antiemetics are needed. We try to give the antiemetics even before ending the OR, and we try to give pain management even before the patient leaves the OR, so that when they get there, they don't need as much, and we can evaluate better how everything is going. But we still have, at a regular base, that we do have to do pain management and give antiemetics. Usually in the beginning, the blood pressure is recorded. We still do that manually. I hope someday soon we will be able to do it digitally. But every 5 minutes for the first 30 minutes, and then every 15 minutes for the next 30 minutes, making an hour. And this usually gives us a good enough trend, long enough trend, to decide how the patient is doing, and if the patient is getting ready to go to the next transfer. What are the pain medications we use more often? Well, we use very often paracetamol. Paracetamol is a good medication, especially if you have to give it rectally or IV, because it doesn't interact as much with other medication like muscle relaxant or sedation, or even aceclummerol, blood thinners. And it has the advantage that you can give it IV or rectally, so it doesn't usually disturb if the patient is vomiting, or if they cannot swallow. The most common NSAID that we are using at the moment is diclofenac, and diclofenac can be given intramuscularly, IV, or even rectally. We do have to keep in mind that it is an NSAID, so sometimes if you have diabetic patients or hypertensive patients or patients that have problems with their kidney, you have to be very careful using this type of medication. A very good medication, pretty safe, is Tramal, which we give usually intramuscularly or IV. Younger patients tend to have more symptoms, side effects, like sweating, nausea, and vomiting. But otherwise, it's a pretty safe drug. We use narcotics called dipidolor and morphine often. And this also has the advantage that you can give it subcutaneously, intramuscularly, or intravenously. We sometimes have problems with patients that either even though we gave them medication and we want to avoid, for instance, the narcotics, or we find that they also have pain and or high blood pressure. And if there are no contraindications, we can use clonidine intravenously. You have to be a little bit careful because clonidine can increase the grade of the block. So if you have a second degree or a third degree block, it's contraindicated to use clonidine. We do use local anesthesia and fentanyl. Usually, if there's an epidural catheter and a pump, they have then usually marcaine, which is bupivacaine, and fentanyl, and they get that epidurally through a pump. PCA is one of the newest addition, and also very well liked. PCA is patient-controlled analgesia, so the patient controls when and how much pain management they want. All they have to do is press a button, and they get the medication. If they press 10 times, they're not going to get 10 shots. They're going to get one shot, and the computer usually waits the programmed amount of minutes. Usually it's about 8 to 10 minutes before they can press again and get a second or a next dose. Okay, this picture shows some more equipment, less sophisticated, like the bear hugger. That's to either warm up the patient, or sometimes you have to cool down the patient, so we can use it for that. Good old blanket is used. Usually we use disposable blankets, so that we have less problems with contamination. This is the bladder echo to see if the bladder is empty. There's different types of models, but basically the idea is the same. You put it on top of the region where the bladder is, and it calculates how much urine you have in the bladder. And this is a very low tech, but very efficient and effective way of treating when the patient is anxious and feels that they don't get enough air, or they're hot, you feel it's too hot, or they have pain. We put a simple old fan, and it gives amazing results. So every PACU is going to have one or two fans to cool down their patients and have them feel like they're getting enough air. Most common post-operative complications we see at the PACU are usually have something to do with the airway, so lack of oxygen, and shunting. So if you have a patient, for instance, that we did lung surgery, or they just got a arterial venous shunt, you can get problems with oxygenation. So the patient is not getting enough oxygen in their blood. So we have to see why is this, what's going on. Do they have a pneumothorax, or do they have an obstruction, a spasm? Why do they have a hypoxemia? So that's one of the most common reasons for complications at the PACU. Then we have to see, is the patient still too sleepy or too sedated, or even the muscular relaxant is still too active. So you get a sagging of the tongue. You can also have patients that suffer from obstructive sleep apnea. You can get, like I mentioned, the laryngeal spasm, and this can be due to secretion, blood, irritable airways, which we see sometimes in smokers. And usually we treat this with hydrocortisone 100 milligrams. Of course, we always give oxygen. There's almost no contraindication to give oxygen. And if we see the patient has not improved, then we call in help, usually the anesthesiologist and one or two more, a nurse anesthetist, to help us intubate the patient. So that doesn't happen too often, but it does happen. Okay, other reasons for hypoxemia is this is not common, or even not happening anymore. We used to use nitric oxide, lajas, which used to give more diffusion hypoxemia, but now that's not common. We don't use nitric oxide anymore because there's no advantage to its use. But you can get hypovolemia because of, like I mentioned, inadequate neuromuscular blockade recovery. Sometimes the volatile agents that we use can give respiratory depression, but you can also get it from the induction agents, benzodiazepines, the narcotics can give this. Sometimes if we hyperventilated the patient, you can have hypocarbia, which occurred intraoperatively. That's why we always measure the CO2. And of course, surgery done in the region of the trachea can cause obstruction, either because of hematomas, or because you can have some other reason, tumors or things like that, that can cause obstruction. You can have increased right to left shunt. Often when we intubated the patient, we tend to give pure oxygen. And usually this is good, but often we don't realize that pure oxygen gets absorbed very fast, and you can get that the peripheral part of the lung can collapse, causing atelectasis. And also, if the patient is not well intubated, or you can have larger parts of the lung with atelectasis, which causes increased shunting, and you can even have a blockade of the bronchus by blood or mucus plugs, or even material. Like for instance, when we do ENT, you can have the adenoids or something like that, or when we do dental surgery, you can have blood, but also pieces of bone and tooth that causes blockade of the bronchus. You always have to consider pneumothorax, especially if the patient just had a central line put in, subclavia or something like that. Sometimes in trauma, rib injury, at first you don't realize, but the patient can develop during ventilation, they can develop pneumothorax. So you have to be aware of these things. Other complications that we see on the PACU are in the more of the nature of blood pressure. We can see hypotension, which occurs very often, especially when we do regional anesthesia because of the sympathetic blockade. C-sections often have low blood pressure. We have to treat that with catecholamines. Also, if the patient bled a lot, you can have that. So there are more than one reason why we see hypotension. Decreased preload, decreased myocardial contractility, ischemia of the heart, maybe old cardiac, heart attacks and things like that, cause that you don't have too much cardiac reserve. But you can also have a problem, according to the Frank-Starling law, that if you have too much afterload, like a high blood pressure, or there's a reason, for instance, in pregnant patients, we can have an increased afterload so that the heart cannot lose the blood adequately. You can also have, like I mentioned, decreased preload, like increased blood loss, increased third space loss, undiagnosed urinary loss, and what we often see in especially diabetics, we see septicemia. You can even have shock where the patient cannot maintain the blood pressure. We see decreased myocardial contractility, like I mentioned, because of depressant effects of general anesthesia drugs. They can have pre-existing ventricular dysfunction, especially if they have heart attacks before, or congestive heart failure. You can see this type of things. And perioperative, the patient could have developed a myocardial ischemia and or infarction. Decreased afterload, also the volatile agents can depress and decrease the afterload. We can be talking about septicemia, which has gone further and became a septic shock. And you can see a profound decrease in this systemic vascular resistance, which could be caused, like I mentioned, by septic shock or volatile agents. Postoperative complication, also very common, is hypertension, which can be due to pain, increased CO2, hypothermia. That's why it's very important to maintain normal temperature, hypoxemia, lack of oxygen, excess intravascular volume, and pre-existing hypertension. Those are causes. Sometimes we can see patients with eclampsia that can have hypertension. So we have to be aware of this. We do see arrhythmias, sometimes because of electrolyte imbalance, like dialysis patients that can have too high potassium or too low potassium. Again, hypoxemia, hypercardia, which the CO2 is too high, you can have arrhythmias. And of course, metabolic acidosis or respiratory acidosis can cause arrhythmia. Like seen in, for instance, diabetics that are not well under control. Postoperative pain and agitation, ascertain of the adequacy of the blood-gas exchange. So if you have a normal hemoglobin, you can pretty much say a lot by the peripheral oxygen saturation. But this is not dependable anymore if the hemoglobin is low. So if you have a good saturation but you have a low hemoglobin, then you don't know if the patient is getting enough oxygen. It's very important to evaluate any gastric or urinary distension. Gastric distension can occur when we're ventilating the patient before, like bagging the patient before intubating. And urinary distension can occur if we did not place a urinary catheter and the patient got fluids and the operation is long enough to distend the bladder. Sometimes we can treat with small doses of narcotics, which will have the patient feel a little bit better. But this is tricky, so we have to be aware that it can also make things worse. Another complication that we see very often is nausea and vomiting, which is frequently seen after laparoscopic surgeries, eye surgery, breast, and gynecology. We treat it with Kitril, Citron, 1 milligrams, IV in adults and children we give 0.1 milligram per kilogram, and also Primperan, metoclopramide, which we give usually about 10 milligrams average for a patient, 10 to 20 milligrams. And dexamethasone is also a very good medicine to give for nausea and vomiting, especially to avoid nausea and vomiting. By the way, propofol is also a very good medicine, but of course it sedates the patient, so you have to be a little bit careful if the patient is vomiting to give them propofol. We often see, especially in C-sections that got spinal, we see shivering, hypothermia. Don't forget that the ORs are always too cold because of the effect they need to avoid contamination. The fluids, if they're not heated, they're cold, and you can transfuse too much cold fluids, which can cause hypothermia and shivering. Cold irrigation fluids used by the surgeon, spinal anesthesia, like I mentioned, because of the sympathetic block you get, that the blood vessels are open, so all the heat goes out. We treat it by warm blankets, warm fluids, the bear hugger, and also if the patient is shivering a lot, you can, with low dose of clonidine, you can titrate intravenously to reduce the shivering. Lately we see less shivering when we're doing the C-sections because what we do is we start a phenylephrine pump before we give the spinal, or during the time that we're giving the spinal, to avoid that the patient becomes hypotensive, and we have seen that they have less nausea and vomiting and less shivering. It's not 100%, but it's better. So when is it good? Is there a special amount of time that you say, okay, now the patient can go to the next ward? Well, like I wrote here, neither an arbitrary time limit nor a discharge score can be used to define a medically appropriate length stay in the recovery room accurately. So you have to use your common sense. You have to look at each patient in every case, maybe even consulting with a colleague or a doctor or a nurse before deciding that the patient is good enough to go to the ward. We even have seen that we find the patient good enough to go to the ward, but the ward find them not good enough to be with them. And of course, you have to be perceptive to this, because we don't know the situation on the ward. We may not have enough nurses taking care of all the patients that are being admitted. So not all patients must be evaluated by the anesthesiologist prior to discharge from the PACU, but they can always consult. The criteria for discharge developed by the anesthesia department, what we do is usually, if the nurses, which are very well trained ex intensive care nurses, when they feel that the patient are good enough and they think it's okay, then the patient can go to the ward or to the daycare department. If they have doubts, they always consult the anesthesiologist. And again, the wards, depending where they're going to. So if they're going home, you are much more strict than if they're going to the intensive care unit or to a regular ward. So depending on where the patient is going after the PACU, that also has an influence on the criteria when the patient is ready to go to the next transfer. Um, we judge several things like can you talk to the patient? Is the patient easily arousable? Is the patient more or less oriented? Of course, often they're a bit disoriented, but you can ask them of their name, you can ask them their date of birth, you can ask them where they are to have an idea how well they're oriented. Um, are they well able to maintain and protect their airway? So can they cough? Can they breathe? Can they stick out their tongue? Sometimes they suffer obstructive sleep apnea. Can they, can we arouse them so that they can breathe properly? Do they have stable vital signs, at least for the last 15 to 30 minutes, depending again what type of operation they did, what type of medication they got? Are they able to call for help? Is there any bleeding? Is there any reason to think that something is not well surgically? Do we have to have the surgeon take a look before the patient leaves? Especially if the patient is going home or if the patient doesn't have a bladder catheter, then it's very important that they can urinate, move their legs, and walk. There's a thing called the Ardrete Recovery Score, which helps to evaluate the patient. For instance, how is the color of the patient? How is the breathing of the patient? How is the circulation? The blood pressure. Are the patient conscious and are they active? And you can give it a score to give you an idea how well they're doing. Of course, if you have a score of 8, then it's the best it can be, because then the patient is pink, can breathe deeply and cough, has a normal blood pressure, is awake, alert, and oriented, and moves all extremities. And of course, an Aldrete score of 0, then the patient is definitely not ready to go to any other ward or translation. So the lowest score, Aldrete score, is between 0 and 2. The score for a patient to be shifted to the next level should be about an 8 at least. And since some patients arrive to the PACU will meet the score of 8, it is very illogical to fix a number to the shifting of the patient. In other words, if the patient came in with a score of 8, even then we often don't quickly or immediately shift the patient to the ward unless there was a local anesthesia or something like that. We still evaluate it because sometimes the patient come in with a good score and then the score can regress a little bit. Ideally, it should be a decision of the PACU nurse or the anesthesiologist regarding the shift from the PACU to the next level of care, taking into account the anesthetic plan and the drugs given intraoperatively, as well as the PACU, as well as in the PACU. But also, like I mentioned before, it's very important that the ward where they're going to can handle the patient at that stage. And going home, of course, the patient has to be close to perfect. And going to intensive care, they can be, as a little bit more sedated, a little bit more complicated because it's a intensive care unit. Okay, this is the post-anesthesia discharge scoring system. Again, they look at the vital signs, they look at the level of activity, if the patient has nausea and vomiting. if the patient has pain, because pain management is very important, we always strive to keep the pain score from 0 to 10 below 4, and preferably below 2. So we know that the patient is going to be doing much better once they leave the PACU. Surgical bleeding, we have to look at the dressing. We have to look at the wound if we can, and determine if everything looks okay, if the patient is not bleeding actively. Sometimes we have to look if it's something vaginal. We have to look underneath the drapes to see if the patient is not bleeding. So actively look for bleeding after surgery. Before going home, the patient should be able to stand and take a few steps, sit on the bed, um, and or stand next to the bed. Should be able to sip some fluids. Should be able to urinate. There it is again. Should be able to repeat post-operative management instructions, and should be able to at least identify his escort. And we never let the patient drive after surgery and or anesthesia, because that would be too much of a risk. Okay, it's time to take a break. If you want, you can stop the film right now and then come back, and we're going to do a case, and then we see an example of how a patient can an example of a patient on the PACU after surgery. Okay, this is a case report. It's a patient, we will call him Mr. Albert, and he is 35 years old, arrives at the PACU following surgical removal of the gallbladder, a cholecystectomy. The surgical intervention using the laparoscopic approach is successful. So it went well. It lasted about an hour and 15 minutes. The patient, Albert, airway and ability to maintain respiratory stability is evaluated immediately. His respiration is 16 times per minute and his heart rate is 78 beats per minute. The oxygen is being administered at 2 liters via nasal cannula. A pulse oximeter is placed on his left forefinger and the oxygen saturation is measured at 95%. The patient is arousable but easily drifts off to sleep. So if we look at this, it seems like an uneventful surgery. Patient is breathing 16 times per minute, which is a little bit fast, but not abnormal. The heart rate is okay, 78. I mean, that's basically normal. The oxygen saturation is good at 95%, even though he's getting some oxygen via the nasal cannula. So probably without the oxygen, you can expect that the oxygen saturation would be lower. And maybe it's not a bad idea to, once the patient is stable at these vital signs, to try stopping the oxygen without removing the cannula, just to see what happens to the saturation at this point. So let's look at the next information. The report is received from the operating room staff. His operative course was unremarkable. Patient history obtained during the preoperative phase of care showed that he was a 2-pack per day smoker and he denies taking any prescribed or over-the-counter medication. Patient Albert weighs about 110 kilos. Further assessment of the patient demonstrates a normal skin perfusion, so the color is good, with good capillary refill at all extremities. He has a drain in his abdomen with a small amount of yellowish discharge. The wound site and the sutures are clean and dry without bleeding or discharge. There is no Foley catheter in place. When questioned, he denies the need to urinate. Completing a head-to-toe assessment shows no other alterations from the baseline. So far so good. The patient smokes 2 packs a day. It doesn't say how long he's been smoking, but 2 packs a day seems like a lot. The tendency nowadays is, because that's always a discussion, should the anesthesiologist tell the patient not to smoke um, acutely before surgery, or should we allow them to continue smoking but encourage them to smoke as little as possible? Well, the last word has not been said yet, but in any case, what I do is I tell them they don't have to stop smoking, because that could cause abstinence and can cause a lot of problems. But we do encourage to smoke as little as possible, and to stop smoking um, for a longer period after surgery. Of course, um, they would need help for this, but in any case, that's good advice. Patient Albert wakes when the second set of vital signs is obtained, so which is about 5 minutes later. He reports that his pain is now 6 on a 10-point scale. He states that he has pain in his shoulder and pressure in his abdomen. Morphine, 5 milligrams, is ordered for the pain, and 4 milligrams is administered IV. So the patient now has a pretty high score of pain. It's not the maximum pain, but it's more than 4. He mentions that he has pain in the shoulder, even though he was operated on his gallbladder. But this is not strange when we do laparoscopic surgery, because the gas we use, the CO2 gas we use to fill up the abdomen, can cause that they mention shoulder pain. And of course, pain in the abdomen can come from the surgery itself. Um, Repeat vital signs are obtained every 15 minutes now. It's been a half an hour for the first hours. And at 45 minutes after admission, the patient's oxygen saturation is noted to be 90%. 90% is not extremely low, but it's not normal. So this should be a little bit point of attention. We should start looking at why is it 90%? Is it that he's not getting his oxygen anymore? Is the pain still not well controlled? Is there another reason why the saturation is low? Ideally, we would like to know what this oxygen saturation was before surgery. And often at this point, you can go back to the anesthesia list and see what the saturation was during the operation. And often at the pre-screening, they also note the saturation. So you have an idea what is normal. If the patient is a COPD patient, 90% may be normal. So we have to look at. If the patient is a healthy patient, 90% may be too low. The PACU staff suctions secretions from the throat, and he is instructed on how to use incentive spirometer. So we're now trying to treat the low oxygen saturation and the respiratory depression by sucking out the saliva and the secretion, and also incentivizing the patient by using a spirometer. His oxygen flow is increased to 4 liters per minute by nasal cannula. By the way, usually we use between 2 and 3. 4 is the high end of using a cannula, because then they start getting, it's too much flow for the nose. You may have to decide to use a mask, a non-rebreathing mask. No change in the patient oxygen saturation is noted over the next 15 minutes, despite compliance with respiratory exercise. So the patient is getting more oxygen and is doing his exercises for breathing, and still the oxygen saturation is not getting better. And this can all mean that we have to be even more alert and continue following this patient closely. And certainly the patient is not ready to go back to the wards at this moment. At 1 hour after admission, the patient's oxygen saturation remains between 89 and 90%. His respiratory rate is 16 breaths per minute, and he is more difficult to arouse. Now, could this mean that the morphine is acting up, making him drowsy, or does it mean that the CO2 is increasing, making him drowsy, or what else is going on? So now we're starting to get a little bit more cautious and worried. The nurse notifies the physician of the change in patient Albert's status. The oxygen delivery is changed again to a face mask, like I mentioned before. at 4 liters per minute without improvement in the oxygen saturation level. All other parameters remain stable, demonstrating a readiness for discharge. Well, you can argue that the other parameters are okay, but still the oxygen delivery is a little bit complicated. Still not as complicated that a ward cannot handle it, so the patient is not intubated or anything. But probably you would want to either keep the patient a little bit longer or make sure that the ward is ready to accept the level at which this patient is now. Despite the improvement in the patient's status, the oxygen issue remains worrisome. The patient is admitted for an overnight hospital stay, and the respiratory exerciser continued, eventually demonstrating an improvement in oxygen saturation to a high 94. The next morning, the patient is discharged to home. So this was a pretty interesting case because normally the patient would have gone home, but because of the way the patient evolved after coming from surgery and remaining on the PACU, the nurses acted very cautiously and I think probably did a safer treatment for the patient. And when the patient went home, he went in a better condition. So you have less worries and less complications to be expected. The assessment of the pain Albert was thorough and well organized, like I mentioned. The ABCs were evaluated upon admission to ensure stability of the patient. The history was ascertained. The vital signs were obtained and the recommended basis. However, despite the excellent care, the patient did not demonstrate adequate improvement in the status to be discharged the same day to his house, except for the next day. The patient's history of smoking may be the cause of the respiratory insufficiency. This is good to think about these things because this is how we learn. And then the next patient that has a similar history may teach us that may teach us that we have to be aware of these type of complications. Whether the patient was honest in his assessment of his smoking habit could be debated. Many patients do not fully and honestly report a cigarette and or drug and all alcohol use. In addition, the patient may not have reported the feeling of nasal congestion, a sign of developing cold, to the anesthesiologist prior to surgery. Had this been shared, the surgery may have been postponed. The patient may have been instructed to cut back on cigarettes use and wait until the cold symptoms subside prior to have surgery. When patients underreport or are dishonest during the preoperative phase of care, the staff caring for the patient in the postoperative care is put into a disadvantage. By the way, something very important also to mention, preoperative, in the preoperative screening and also before starting any anesthesia for surgery, is to know if the patient has an empty stomach. So it's very important, and we also always try to explain to the patient why they should not eat or drink before surgery. And the reason is that if you vomit and you are under anesthesia or you are sedated, you cannot protect your airway as effectively as needed. So the food can go to the lungs and cause even grave complications. Okay, the next picture is a summary of all the things you can look at.
Hi, welcome back. This is Tracy. We're going to finish up with postoperative care, chapter 18 in your IGGI book. We're going to start talking about when postoperative care starts and how we're going to take care of our patients throughout this period. So postoperative care begins when surgery has been completed and our patient is then transferred into the post-anesthesia care unit, or PACU. Same-day surgery units, when you're working in same-day surgery, they typically will go to the PACU for a brief period of time and then back to the same-day surgery area. And then patients will be discharged from same-day surgery, or if they require hospitalization post-operatively, then they'll go back to the regular med-surg floor and then be discharged from those areas as well. Typically, with the taking care of the patients during this time, they're going to be monitored very, very closely. You can see in this picture there's a lot of stuff going on, lots of IV drips, things like that. Typically, vital signs are going to be every 5 minutes. We're going to be looking at level of conscious changes, going to be monitoring pulse oximetry, going to be checking those incision dressings. We're going to be looking at those very closely, monitoring things very closely, because this is the time that our patients are going to be very fragile and require close monitoring, things like that. The post-operative period will continue after the patient's condition is stabilized. The patient is discharged, and then until they have that follow-up with the surgeon in that post-operative period, that's the length of time that it will be. So sometimes people will be in a quote-unquote post-operative period for several weeks. Maybe they don't see the surgeon for a week, maybe 2 weeks. So you can consider that time from discharge from the operating room all the way through till they're discharged. So let's take a look at this really great mind map. And when you're looking at this, you will see respiratory status is the #1 concern. Oftentimes when patients are extubated, laryngeal spasms can occur during that time. And really the only way to take care of our patients when they have these laryngeal spasms is to initially call for help and get them oxygen, and the nurse anesthetist or anesthesiologist will probably have to come and give them a little bit of Valium, something to cause those muscles to relax so that we don't end up losing that airway. So airway, #1 concern. Take a listen to those lung sounds, especially if you're taking care of patients that have congestive heart failure and we're giving a bunch of IV fluids during surgery, prior to surgery. Be listening to those lung sounds, making sure they stay nice and clear, having our patients cough and deep breathe, watching for that gag reflex. Sometimes patients will have oral airways in, but be looking for all of these different things. So it talks about positioning, suctioning, coughing and deep breathing. Do they need to be on mechanical support? So are they going to be on a ventilator post-operative? So just a few different things to think about. When you are receiving report in the PACU, make sure that you get a good detailed report. And when you look at this little lady right here in her green, they want to know how the patient tolerated it, the type of surgery, the type of anesthetics, results, complications, INOs. So things like that, just make sure that you're getting all of that information so you have a good knowledge of what your patient just went through. When patients wake up in that immediate post-operative period, typically they are forgetful, confused. So we need to make sure that we continue to reorientate them, so letting them know where they are, know that surgery is over with, know they're doing okay, let them know that the surgeon has visited with their family. We try to keep it a fairly quiet environment and explain all the procedures. And sometimes it'll feel like you are explaining the same thing over and over and over, and you might want to strangle your patient, but rest assured, once that anesthetic has worn off, things will get better. When can our client return to the room? See across the bottom of this slide, when vital signs are okay, when they're awake, the dressing looks good, and they can maintain their oxygen saturations. And then make sure, like I said, be checking that incision area for drainage, watching what that looks like. Post-op complications, we had addressed those a little bit in the previous presentation, but so with, if you look across the board as far as lungs go, atelectasis, hopefully you all know what atelectasis is. If you don't, take a moment to look it up. But with atelectasis, we'll see dyspnea, tachypnea, decreased breath sounds, asymmetrical chest movement. So this is the importance, prevention of atelectasis, prevention of pneumonia. That's why we need these patients to cough, deep breathe, use their incentive spirometries. We want to get all of those secretions that are sitting in those lungs, get them up, get them moving. Urinary retention, we see urinary retention very, very common with spinal or epidural medications administration. If our patient is not able to void 8 to 10 hours post-operatively, palpate over the bladder, probably going to do a bladder scan, and then take that evaluation assessment from there and then notify your physician. People that have the spinal anesthetics will oftentimes have a Foley catheter. We leave that Foley catheter in for about 24 hours so that they don't have trouble with this urinary retention. With circulatory pulmonary embolism, shock going to be common when we're looking at our incision sites. Make sure that we don't have any infection. The diabetic patient is going to be at increased risk for infection due to blood glucose levels. We're going to talk about dehiscence and evisceration, gastric dilatation, so are they having continued nausea, vomiting, abdominal distension. And then the paralytic ileus is postoperatively if our patient is unable to pass flatus, have any bowel movements, decreased bowel sounds, those kinds of things be looking for. During the PACU recovery time, our patients will begin their stabilization. It's typically very close to the surgical suite in case something would go wrong and our patient would need to go back into surgery. Adults are typically separated from children. We typically use privacy curtains between patients because there's not just individualized rooms in the PACU, because we want people to be able to move freely, especially during medical emergencies. So we're going to make sure that these patients have access to oxygen, suction equipment, cardiac monitors, pulse oximetries, maybe capnography, airway equipment, and then all emergency drugs that would be necessary for resuscitation. Recently, as you can see on this slide, the Joint Commission's NPSG, which is National Patient Safety Goals, require that anesthesia care providers and the circulating nurses give the PACU nurse verbal handoff reports. In a way that this is important is that we want to have this open line of communication and be able to talk about the patient's condition and what kind of needs they're going to have. So it is a two-way verbal interaction between the health professionals. When the PACU nurse is receiving a report, we don't want to have any interruptions. There's usually a standardized way of presenting the information so that every patient is given really pretty much the exact same handoff, or at least the exact same information is included in that handoff. They give time for the receiving nurse to think about the report, to ask any questions, and take time to just get a good understanding of what the patient is going through. Your PACU nurses will have extensive knowledge in advanced cardiac life support. They have very good skilled assessments. They're able to make very quick decisions in emergency scenarios. So if you look at page 285 in your IGI, on the top of that page, chart 18.1, you'll see best practices for patient safety and quality care. And it does list out a postoperative handoff report. So what I'd like you to do is take a look at that and be cognizant of it. So when we talk about that in class, you'll be able to come up with answers for me. PACU functions for the nurse. She is going to be primary responsibility of assessing our patients. So watching respiratory rates, level of conscious, TPRs, pulse oxes, blood pressures. Want to make sure that she is examining that surgical area. If there's any drainage on that dressing, it's going to be important that that area is outlined, timed, and dated so everyone is aware of how much drainage is presenting and those types of things. So it's going to be very important to watch those dressings very closely in that PACU. And then she determines when that patient will be ready to be discharged from the PACU using the Alderette score. Postoperative care goals. So these are goals to be able to leave the PACU, but they're also goals for our patients to be discharged from. So we want to make sure, first and foremost, that they have excellent respiratory function, that they're using that incentive spirometry, that we have adequate hydration, especially if someone has very thick, tenacious secretions from lungs. For bowel sounds, we typically keep them NPO or ice chips, clear liquid diet until GI function returns. Will they have an NG tube? It's kind of depending on what type of surgery they have. So it's our job as nurses to listen to bowel sounds, record those bowel sounds, record passing flatus, record any bowel movements, and then we will be responsible for progressing that diet, because typically what you will see is a physician's order that says progress DAT, so progress diet as tolerates. For management of cardiovascular function, we need to be looking at hemoglobin hematocrit. We're looking at skin color. How are they tolerating activity? Early ambulation is going to be very important for our surgical patients to prevent thrombosis, DVTs, pulmonary embolisms, all those kinds of things. We do want to take a look at fluid and electrolytes. So are they on a continued IV rate? Are they sipping? Are they drinking? Watching those fluid and electrolytes, and then any drainage. And then for comfort, we do want to make sure, it talks about analgesics. So are we looking at the opioids, or are we able to step down to something else? Antiemetics for vomiting and nausea. Hygiene, if they're sweating, diaphoretic, when they first come out of surgery, they have all that scrub solution on them. So let's get them cleaned up, bathe them, get them in a clean gown. You guys all know it seems like if you take a shower, you feel a little bit better. So at least give them a bed bath, clean them up. And then also promoting as much rest as we can. With our respiratory assessments, the biggest thing is, do we have a patent airway? If they have an artificial airway, we need to note that. Sometimes you will see that they have an oral nasal, or they will have an oral airway in, and when the patient wakes up, that's when we determine when to take those airways out. Looking at the rate, pattern, depth, always take a listen to those lung sounds. Watch how they're breathing. Listen for any snoring or stridor. If they have stridor, it would mean obstruction. So then you need to be thinking about getting help. And then respiratory depression or hypoxemia, because you need to consider these patients have had quite a few medications, so we want to be watching that. With the cardiovascular assessment, vital signs is going to be a great way to assess them. We want to ensure that their heart rate, blood pressure return to 10 to 15% of the normal prior to discharging them from PACU. Monitor for VTEs, and we'll talk a little bit more about those, but we really don't want our patients to develop any venous thromboembolus. So be looking at those, watching your cardiac monitor. If they're in a different rhythm than what they were in the preoperative phase, we need to be continuing watching that. Listen to heart sounds, make sure they're still regular if they were regular prior to surgery, and if they were irregular, make sure that that's a consistent finding. Neurologic system. With the neurologic system, we're just going to be assessing our patient's level of consciousness, and as I said, they may seem confused, disoriented, those types of things when they initially wake up, but as time progresses, that will improve. So we do want to make sure that we are taking a look at the neurologic functioning. Compare the patient's baseline neurologic status that was obtained prior to surgery, and make sure that it's comparable with the findings post-operatively. Watch their motor function, sensory function. Are they able to feel? Are they able to breathe independently? And then test for return of sympathetic nervous system tone by gradually elevating the head of the bed, and then watching how that patient reacts. Are they having any orthostatic hypotension changes, or are they able to tolerate that? With our epidural or spinal, we do want to be assessing those dermatomes and the dermatome level. So we're going to be asking our patients if they can feel us touch them, if it's dark, if it's dull, if it's sharp, and how they're able to move. The last thing I want to talk about, you need to be aware of this, is the Alderete scoring. So this is how our patients are decided upon being discharged from the PACU. So they have to have a minimum score of about 6 prior to leaving the PACU. So it takes a look at how can they move, how are they breathing, are they fully awake, and then watching their pulse ox and blood pressures. So I will stop here, and we will finish up with one more brief segment on post-operative care.
Okay, thank you very much for listening, and I hope you enjoyed this. Take care.